I'm Carson Cristiano. I'm the Executive Director of CIGA, the Center for Effective Global Action, based at UC Berkeley. I'm so excited to be part of this event today. It's really become a highlight of our year at CIGA, and it's hard to believe that this is the second time that we've done our annual event online. I guess a marker of how long we've been interacting with one another from behind our screens, but the end is near, I believe. I hope that the talks that you hear today inspire you to reach out to some of your new colleagues and collaborators, and something that we're happy to facilitate if needed. So by the way, I know that Sam mentioned this earlier, but if you haven't already, or if you've just joined recently, please take a moment to introduce yourself. If you click on the chat box at the bottom of your Zoom window, you can just say who you are and where you're from, your affiliation and location. So right now, I have the pleasure of introducing our keynote speaker, Ziad Obermeyer. Ziad is the Blue Cross of California Distinguished Associate Professor of Health Policy and Management at UC Berkeley, the School of Public Health. He's also a CIGA faculty affiliate. Ziad's research uses innovative econometric methods and machine learning to analyze medicine and health policy. And among other applications, Ziad has used algorithmic methods to analyze racial bias in healthcare and to help healthcare professionals use predictions in their decision-making. So in addition to what he'll present today, I really hope that if this is a topic of interest, you'll check out his other work online. And in his previous life, Ziad was an assistant professor at Harvard Medical School, where he received the early Independence Award, the National Institute of Health's most prestigious award for exceptional junior scientists. And Ziad continues to practice emergency medicine in underserved parts of the United States. So today we'll hear Ziad talk about the use of predictive methods for targeting health resources. And I'm sure this will raise a lot of questions from our audience. So we're going to reserve 10 minutes at the end to address as many of them as we can. If you have a question, please go ahead and type it into the Q&A box at the bottom of your screen. So Ziad, please take it away.
Thank you so much. So I thought I would start by telling you a little bit about my work on how bias gets into algorithms. And I know that this is, it's a topic that's intrinsically interesting, and I've been interested in it for a while, but I also think it has a lot of broader lessons for how we think about targeting resources in the US, but also in a lot of development research settings as well. And so I wanted to kind of like, with that framing, try to cast a lot of what we do in public policy and in development as targeting resources. So what do I mean by targeting? Well, targeting is actually its own prediction problem. By that, what I mean is we are often in this position where we observe a complex set of data about some unit, whether it's people, places, countries, things like that. And we need to distill those complex measures into some index of need for resources, and allocate resources accordingly. And that task, that prediction task, is one that algorithms do very well. And so I think it's really exciting that as we get more and more data available, as we have more and more sophisticated algorithms and computing power, this targeting prediction problem is going to be solved more and more efficiently and at broader scale. So I think that's largely a really good thing. And a lot of my work is trying to come up with algorithms that help doctors and policymakers do that better. But along the way, algorithms can also reproduce, and in a lot of cases, even scale up bias. And that bias comes from the data sets that they're trained on, but it comes, as I'm learning through a number of projects that I've done over the past few years, it largely comes from one particular problem that I think is underappreciated relative to its importance. And that problem is all about the variable that the algorithm is trained to predict. So kind of what we traditionally think of as the left-hand side of the equation, that's where a lot of the bias gets into algorithms in health, and I think much more broadly in other sectors. So I want to give you two thumbnail sketches of examples that happen to be in the US, but that I think have really broad lessons for both algorithms and more broadly for these kinds of targeting problems. Okay, so here's the first case study. So this is a case study about how hospitals manage complex chronically ill patients. So in every health system around the world, there is this problem that a small fraction of patients with large healthcare needs because of multiple chronic illnesses and comorbidities and exacerbations of those comorbidities, they have both high costs for the healthcare system and kind of poor fragmented care because they're bouncing around from different places and different parts of the healthcare system. So in the US, just like in lots of other places, the healthcare system has invested in ways that we can target resources to those people today to prevent these kinds of problems tomorrow. So if I manage to get someone their medications refilled and convince them to take them and help them with any financial needs, get them in to see their primary care doctor, I can keep them out of the ER next week, out of the hospital. I can improve their health by preventing problems, and I can save the healthcare system a lot of money. So everyone wins. As you can imagine, having all that extra attention, those extra resources, is itself expensive. And so you need to target that resource to people who need it. And this is where algorithms come in. So we have this complex set of health data that we see about lots of patients, and we want to identify those that are really going to need healthcare so that we can help them today. So just to give you a sense of scale, in the US, the whole market of algorithms that basically help health systems with this task is about like 150 to 200 million people who are screened and put through these algorithms every year. So kind of the majority of the US population. We're going to be studying a particular piece of software by a particular company that's emblematic of this whole sector. This particular one affects only 70 million people per year. So the scale is really enormous, and I think this is not restricted to the US. What all of these algorithms do, the stated goal is find people who are going to get sick. So I've got this population of patients that I'm charged to take care of that I have today. Some of them are going to deteriorate. So I want to find those people today so that I can prevent that deterioration. So what all these algorithms do is they look ahead over the next year and they see, okay, who's going to end up in the hospital, in the ER, consuming lots of healthcare resources as measured by future healthcare costs, and predict that future, and then rank people by risk and target the highest risk people whose health is going to deteriorate as measured in this way with these extra help programs. So just to give you a very concrete flavor of how that works, imagine that the algorithm is producing some distribution of risk scores for a whole population. At the particular health system that we were working with, the top couple percent were fast-tracked into this extra help program. The next half approximately were run through their doctor to ask, would this patient or that patient of yours benefit from this program? And the bottom half were just kind of not considered. So they were just screened out. Overall, what this means is that the algorithm score is a huge determinant of how you get treated, of your likelihood of getting extra help with your health needs under this program. So we were interested in studying racial bias in that algorithm. To study it, you need to define it. So our definition is grounded in the use of the algorithm. And the principle here is that two people with the same algorithm score are going to be treated the same way. Either they're going to be fast-tracked into that program, or they're going to be screened out, or something in between. So they should have the same health needs, and the color of their skin should not matter. But that's not what we found. So I'll show you two graphs that look like this. Let me talk through the axes. The x-axis here is the algorithm score. So we're just ranking people in percentiles from low on the left to high on the right. And the y-axis is one of many measures of health that we looked at. They all have basically the same result. This one is a count of how many times one of your chronic conditions flares up and requires you to go see a doctor. So if you see your primary care doctor or end up in the ER with heart failure +1, we just count that up over the next year. The two lines show two populations of patients. The top line shows Black patients and the bottom line shows white patients. And what you can see is that no matter where we are in this risk distribution, the Black patients line is above the white patients line. So at any given algorithm score, people who are treated the same way, Black patients have higher needs. It's a little hard to get a sense of the scale of this from just comparing the lines. So let me give you a concrete statistic. If we just look at this high risk group, today it's 18% Black. If we simulate what an unbiased algorithm would look like, it should be 47% Black based on the health needs of Black versus white patients. So this is a really large amount of bias, and it's a very large scale. This is just one of many algorithms that are being used for this purpose. So a really important question that we wanted to answer is, where is the algorithm going wrong? How does the bias get in? And the most important clue that we found is where it's going right. So on this graph, the algorithm score is still on the x-axis from low to high. But now on the y-axis, I'm showing you healthcare costs. So over that next year, not what happens to the patient's health, but what happens to the costs that they generate. And what you can see is that the algorithm is doing a really good job of predicting who costs the healthcare system money, and it's doing a good job for Black and white patients alike. So what that means is that the algorithm is biased for its prediction of health, but it's unbiased for its prediction of cost. Why is that? Well, because Black and white patients have very different relationships between those two variables, between the health set of variables we looked at and the costs. That's because not everyone who needs healthcare based on their health gets healthcare and generates costs. White patients have better access to healthcare. This is not a statement about insurance. All the patients that we studied here had Medicare or private insurance. So, good insurance comparable to what you'd find in many other countries. But even with insurance, in all the ways that poverty makes your life difficult to schedule appointments, to get childcare, to get transportation, those barriers to access mean that Black patients are less likely to get care and generate costs when they need healthcare. In addition, the healthcare just treats Black patients differently. There are many studies showing that doctors are less likely to refer Black patients for advanced testing or treat their pain with medication than white patients. So what that means is that conditional on health, taking two patients with the same health by any measure of health you want to use, Black patients have lower costs on average. And that means that if you train an algorithm to predict healthcare costs, and it does that accurately, you are also training it to be biased for predicting healthcare needs. So one thing that we found as we worked with the particular company that made this algorithm, and as we've worked with a range of partners in the healthcare system, is that we can actually retrain the algorithm and retrain it to predict measures that are closer to patient health, not proxies for health like cost. One key insight is that even if you just cared about predicting costs, predicting health does a pretty good job of predicting costs. And that's because those two variables are very correlated. Sick people do generate healthcare costs on average, and that's true for both Black and white patients. So it's not an unreasonable choice to train an algorithm to predict cost as a proxy for health, but it is a biased choice. So retraining the algorithm to predict measures that are more anchored in patient health and less in health care is going to generate far less bias while predicting all the things we care about pretty accurately. So the thing we took away from this is that getting that target variable right for the algorithm has huge return. It really matters. And I think this will be familiar to you in another form, which is sometimes called Goodhart's law, which is that measures make bad targets. So in the same way that when we incentivize teachers based on test scores, we get better test scores, not necessarily better learning. When we reward algorithms to predict some variable A, even if we're hoping they're going to predict B, they're going to predict A. So that's our first example, and that was a clear example about algorithmic bias. But I want to step back now to a setting that is, I think, one step closer to the settings that we're more used to working in development, which is national healthcare policy. And it's still in the US, but I think it still has a lot of lessons for outside of the US. And this is a story about COVID-19, which, as you all know, was not just a shock to patients' health. It was also a huge shock in the US to hospital finances. So not only did hospitals have to care for a bunch of patients who needed ICU level care and lots of interventions, they also had to shut down their normal operations. So there was a real worry that a lot of hospitals would just shut their doors permanently under this financial strain. So in the US, the solution to this was under the CARES Act, which is a big piece of legislation, there was a provider relief fund that was charged with distributing $175 billion to hospitals and other parts of the healthcare system, basically to keep them solvent and to deal with the costs of providing care for COVID patients. So that's the mandate of the legislation. The legislation gives us two goals. One, get the money to health systems that are most affected directly by COVID-19, caring for COVID-19 patients. The second is to offset some of these losses due to COVID-19. So that's kind of like the abstract goal, and I think that's what Congress does, is set goals. But when that legislation goes to the people, the technical people who need to figure out how to distribute that money, those technical people need to make some hard choices, which is, how do I get this money out the door? How do I solve that prediction problem? So here's how we did it in this case: is we allocated that $175 billion largely in proportion to the revenue that a hospital booked the year before COVID. And so there are some nuances and some workarounds and hacky solutions for targeting it a little bit better. But the dominant choice that was made was to distribute the funding proportional to hospital revenue. Now, this sounded familiar to us, and I think it might sound familiar to you. When we were looking at the algorithm for targeting this extra help program to hospitals, the desired target was patients who needed a lot of healthcare. The proxy measure we used to target the algorithm, and thus the program, was patients who used a lot of healthcare resources. Similarly, in the CARES Act funding, we wanted to target hospitals that had high needs due to COVID, but we targeted, in practice, hospitals that used a lot of resources. So we were interested in seeing whether the same kinds of problems that affected the algorithm we studied would also be affecting this $175 billion of healthcare. So we just mapped where the funding was going at the county level. And the county level lets us get insight not just on the hospitals in that county, but also the underlying population of that county, independent of whether they're coming in to get healthcare or not. So we can assess at this fine-grained geographic level the targeting of funds and any distortions and inequities that that targeting might have produced. So here's what we found. This is just the correlation between the CARES Act funding per resident in a county and the annual hospital revenue of hospitals in that county. And as you can see, those two things are very correlated, which is unsurprising since this is the dominant measure that was chosen to target the funding. This correlation is a lot less tight. So this is now the correlation between COVID-19 reported cases and deaths, kind of combined into an aggregate score on the y-axis, and again, that CARES Act relief funding. And you can see that this is a much bigger spread. So there's a fair number of places that are getting lots and lots of CARES Act funding, but not having a lot of COVID-19 deaths at the bottom right. There's a few places that are getting very little money and have a lot of COVID-19 cases and deaths at the top left. Similarly, even though there's some relationship between the chronic illnesses on the y-axis that make COVID worse and funding, it's a lot less tight than the correlation between revenue and funding. And finally, again, a very loose correlation between measures of hospital financial health and the amount of funding. So basically, the funding is doing exactly what we wanted it to do. It's going to places with high revenue, but it's far less well targeted to these other measures that are closer to the needs that COVID is imposing on hospitals and patients in those areas. So that's on the targeting front. On the inequity front, we can also look at this separately by Black versus white counties. So we've separated out the top quintile Black counties in that top line. And this graph shows you COVID-19 death rates. So just the COVID-19 death rates as a function of CARES Act funding per resident for Black counties versus white counties. And as you can see, two counties, if you draw a vertical line, two counties getting the same amount of funding will have very different COVID death rates as a function of whether they are Black counties or not. And on average, these Black counties getting the same level of funding as white counties had twice the COVID burden. And that's measured by deaths, by positive tests, by total mortality rate during the pandemic, and by hospital operating margin, days of hospital cash on hand. For all of these measures of actual needs, as opposed to hospital revenue, Black counties are doing far worse, even though they're getting the same amount of funding per capita. So, what we took away from this is that not just from these two examples, but from a lot of our work in healthcare, these kinds of distortions due to choosing a label that is biased are very widespread. And it's not just related to health. In other fields as well, you see echoes of this. So in criminal justice, we're often interested in someone's intrinsic propensity to crime, their likelihood of committing another crime. But we don't observe someone's propensity for crime. We observe another variable called arrests or convictions, and that is not an unbiased readout of someone's propensity for crime. Similarly, in labor, we're often interested in employee quality, but we don't observe someone's intrinsic quality. We observe the ratings that other employees or managers give them, again, incorporating lots and lots of racial, gender, language, socioeconomic biases. So this is a very big problem in lots of areas where algorithms are used. And as I showed you, also where policies are used, policy algorithms, you can think of them as. I think there are a lot of similar problems. Again, this is a little further from my area of expertise, but in development, where much like in health, we see cool new data that are coming online, and it's very clear that these data have vast potential. And we focus on methods that we can use to put it on the right-hand side. So this isn't just standard things you put in a regression. Now you need to learn about machine vision algorithms. And I think a great example that I know that this conference has focused on in the past is nighttime lights. And I think nighttime lights are a great example of this, because we're very interested in the potential of these data. But what's less clear is if the satellite imagery is on the right-hand side, what's on the left-hand side? So let me share with you two quotes that I really liked when I was reading about this. So this is a famous picture that you've all no doubt seen, which is the Korean Peninsula. And I think most of you, and certainly when I looked at this picture, I found myself, as painful as it is to say, agreeing with Donald Rumsfeld's take on this image, which is that South Korea is filled with lights and energy and vitality and a booming economy. North Korea is dark. But the more I learned about this area and about the challenges of using these kinds of data, the more I found myself agreeing with the North Korea main daily newspaper, which in response to Donald Rumsfeld's comments wrote, "The essence of society is not flashy lights." So I think that, what is on the left-hand side here? There's a great study that was in a World Bank working paper that actually explored this same topic. And it found that these nighttime lights data are actually pretty complicated to use as proxies for a lot of the socioeconomic variables we care about, because they're noisy, they're unstable over time, they have little explanatory power. There is one thing that nighttime lights turned out to be very good at measuring, which is nighttime lights and electricity consumption. And so I think for me, this really illustrates both some of the challenges of working with these proxy measures and figuring out what we're using these data for, but I think also the lessons, the positive lessons that I took away. So from our work, what we found is that these distortions, as large and as widespread as they are fixable. So we've been working over the past year with a number of healthcare systems, insurers, tech companies, and regulators to actually fix bias in algorithms. And in the same data sets and using the same methods that were used to train the original biased algorithms, we've gotten great results in reducing bias and turning these algorithms from things that reinforce structural inequalities and all the things that we hate about our healthcare system and our society more general, into tools for targeting resources in a both efficient way, because the resulting target of the algorithm is closer to the thing we really care about, and in a more equitable way as well. And I think that there, when I look at the literature in this field, and I'll just highlight a few SIGA affiliates, I think there are similar huge returns in measuring development to doing really, really careful work to getting the labels right. And so I think Josh Blumenstock's work on really targeting these micro level detailed measures of poverty and need for relief, for credit, for things like that as an example. There's amazing work on targeting fraud that has to grapple with these issues that only detected fraud is reported, not investigations, not non-fraudulent cases. Saul Shang has done this amazing work on using these complex data sets to get insight into climate impacts. So I think there are just these huge returns to this careful work that's not just trying to take flashy data and turn it into some omnibus measure of everything, but really focusing it in on real problems and developing real solutions. So I think that this whole enterprise is really built on a foundation of very, very careful empirical work. And I think that plays to the particular strengths of this community at the World Bank, at SIGA, in the broader development community. So let me stop there, and I think we've got a little bit of time for questions.
That's great. Thanks so much, Ziad. Really interesting work. And I have lots of burning questions, so I'm just going to start asking them, and then I invite anyone from the audience to type additional questions into the Q&A box here. So I'm encouraged to know that at least the partners that you've worked with didn't intend to optimize things like cost at the expense of health. And they were open to working with you, an academic researcher, to reduce bias in their algorithms. And you just mentioned a few other SIGA affiliates that have been working to reduce algorithmic bias in the context of like determining credit risk, for example, or identifying people who need emergency aid, which is really exciting work. But of course, this leaves me, and I assume others in the audience, with this question: are these partners the exception, or are they the norm? And what needs to change to ensure that there are adequate checks on the algorithms being developed and used to make potentially life or death decisions for millions of people?
Yeah, great question. So I think I have two thoughts on this. One is a maybe Pollyanna-ish optimistic one, and one is a little more cynical. So on the optimistic side, I don't think this is necessarily true, but in these targeting problems, there is this tendency for better measures of targeting to actually be both more efficient and more equitable. So we're used to thinking about trade-offs between efficiency and equity, and I think that's often the case. But think about what these targeting problems are doing. The closer we can get, the more accurately we can measure who really needs help, the better we're going to target scarce policy dollars. So policymakers are happy because the dollars are going where they're supposed to be going. But there's an intrinsic equitable nature to that improved measurement process. The better we target things to people who need them, the more people who need them are going to get help. Who needs help? Well, disproportionately non-white people in the US, poorer countries in a development setting. So I think that aligning these measurements is both in the interests of policymakers who want the greatest return on their dollars, and also has this huge dividend for equity as well. Again, I don't think that's necessarily the case. It just so happens that a lot of the nature of targeting makes it conducive to avoiding the usual efficiency equity trade-offs we see elsewhere. I think there's another dimension, which is that in this moment in the US, and I think in lots of other places, everyone wants to do something about race and bias, and everyone wants to be seen to be doing something on race and bias. And if you look at the range of things that governments, companies, other people can do, this is a pretty cheap thing to do. That has a pretty big impact, both in terms of public relations, but in terms of real impact. So I think this is a pretty attractive investment for a lot of on a cynical level, just for people who want to get the most PR and bias reduction at the lowest cost, because fixing an algorithm is pretty cheap. Like we do it with a couple PhD students or a couple of RAs, and it's not that expensive.
I was going to say, can you explain to everybody why it's so cheap? We don't exploit graduate students.
Yeah, exactly. It's founded on our own inequality and bias in academia, but it is, I think that there are certain times when you need to do new data collection, and that's expensive. But what we found is that a lot of times in the same data sets that you've trained a biased algorithm, you can just retrain an unbiased algorithm, and it requires more data cleaning. And I think that's what I was alluding to with like the careful empirical work of understanding where the selection bias is, where I measure things, where I don't. So it's not cheap cognitively,
Right.
but it's cheap economically, because it's just like, me and some RAs.
Exactly, which leads me to my next question, which is that, it's one thing to suggest that, it's one thing for a decision maker or somebody developing an algorithm to say that they want it to be less biased, but it's a totally different thing to actually design and implement algorithms that are equitable and fair. So, what is in your experience, to what extent is this a training or capacity problem, and how can we begin to address those gaps?
Yeah, so when we first started working in this area, we were very lucky and kind of surprised that we got a lot of publicity around some of our articles on algorithmic bias, and so we used that to basically build a bunch of collaborations, largely in health, but also in some other areas, finance and criminal justice, where we basically just worked with a ton of organizations to inventory their algorithms, assess them on their risk of bias, and try to roll out some solutions. So we did that both because it's really wonderful that people are when you're an academic, it's just nice that someone's reading your paper and wants you to do something. But so that was very gratifying. But we also used that to essentially learn about a whole cross section of organizations, algorithms, settings. And what we've done is we've distilled that into what we're calling, for lack of a better word, a playbook. So it's a document, and our target audience is like the leader of an organization who wants to do something in this area. That person should be able to just send this document to their technical team, their chief data officer, whoever it is. And it's just a way to work through exactly the kinds of things that we've been doing with all these organizations. So we've tried to make it as practical and concrete as possible. We're releasing that soon. This is in collaboration with the Center for Applied AI at the University of Chicago and my co-author, Sendhil Mullainathan. So that's on the kind of like, internal change grassroots side. We're also working with a number of regulators. So this is like state attorneys general, federal regulators, to essentially issue guidance for industry, because this is actually a new area. And I think that all of our experience with people who are developing algorithms is that they don't mean to make malicious or biased software. We're all just learning about what this field is and how to design algorithms that work well and how to avoid bias. And so they need guidance, and they need to know what are the things I need to do in terms of documentation of algorithms that doesn't reveal trade secrets, but that keeps documentation on the record, ways to train algorithms, ways to assess for bias so that I don't get in trouble. And so that's both a kind of guidance and also the stick part of the incentive structure, where if you deviate from these rules that regulators are setting up, then you open yourself to risk of litigation.
Are there examples of regulations that already exist that are good models for what you'd like to see more of?
Surprisingly not. I think it's
so it's the Wild West.
Yeah, it is it's very Wild West like. Yeah.
And I know that the examples that you gave today were both based or all based in the US, but you've started working with partners in low and middle income countries. What's your sense of how the Wild West of low and middle income countries differs from the Wild West of countries like the US in terms of regulation?
Yeah, I mean, I think in terms of regulation, it is very hard. I don't have a lot of insight into that. I think where I have more insight is in the data infrastructure. And so, of course, as everyone knows, the data infrastructure is just less well developed. That is both a challenge and an opportunity. And the opportunity, I'd say, is to build it right the first time. So a lot of our data infrastructure in this country, in healthcare, the area I know best, is just fundamentally focused on capturing transactions between insurance companies and healthcare providers. And so that's where a lot of the biases that we study come from. It's just because dollars are so convenient, because the whole system, the whole data infrastructure is built on money changing hands. And that intrinsically disadvantages some people. I think that, if we have a chance to build data infrastructure from the ground up in a way that measures health, not dollars, I think we can do a much better job. And I think we're starting to do that with some of our other projects, where we're trying to build up health data infrastructure around focused clinical problems, but at least it's hopefully the grain of sand, which, something better can form.
Can you talk a little bit more about the data gaps? I mean, your examples show that you can do a lot with data that's messy and that's complex, and that you can make improvements in terms of targeting resources more equitably. But to what extent does the existence of underlying data, the availability of the data, and the format of data a problem?
I think it's a huge problem in the following sense, which is that policymakers don't have a lot of time, bandwidth, whatever, to come up with like perfect measures. Researchers want to write papers. Funders rarely fund big data infrastructure projects. So all these forces basically push people to use convenient measures, in our setting, like dollars, instead of like more detailed measures like health. And so, of course,
like health, can you elaborate on that just a little bit? Like, what kind of information about health would you need, for example, in some of the cases that you presented today?
Yeah, so if you look at the, I think the COVID funding is a great example. So we were using these measures of like COVID cases and COVID deaths. And we found these huge disparities in those measures. But even those measures are kind of crappy because how does a county have a high COVID case or death numbers? Well, it's because the county has a lot of testing resources. So what about the people who, so we're like, okay, so we can't just use that. So now we need to use total mortality over the pandemic to compensate for that and to find people who are dying without a COVID diagnosis. But then that doesn't capture people who get really sick. So it's like, okay, how do we measure getting really sick? Well, we've got these data sets at the county level that are surveys of the prevalence of chronic kidney disease, of emphysema, of diabetes and hypertension that we know makes COVID worse and more severe. So we can fold those in. So it's just this like very complex effort of triangulating across all these different data sets. So, case notifications, hospital records, representative surveys, death records from Social Security. So it's just like, that's the kind of work that this requires. But that's the kind of work that I think is in short supply for people who, understandably need to move quickly and I guess not break things, but deliver aid to people in an efficient way.
So, I mean, what would you actually? There's a question from Neha Dagonkar in the Q&A about, how do we determine what the right predictors are? And I'm wondering, there's only one Ziad Obermeyer and your team, like,
Thank God. Yeah.
Hopefully there are many more, students and faculty becoming more, training up on these topics and starting to work with these types of partners. But how can decision makers decide what the right predictors are? Do they need academic partners? Can they do that on their own? I guess the guidebook or I forget what you called it, will be really important, perhaps, in helping them do that.
I hope so, but I think, I'm going to give a very unsatisfying answer, which is that there's no generic solution. So, I think, and in fact, I think this is a little bit similar to kind of the uses and misuses of GDP in development. GDP is a very specific thing. It's useful for very specific context, but it is not a all-purpose measure of goodness. It is not, as the DPRK daily said, the essence of society. It's not GDP. So there's no generic, proxy that's going to be good for lots of different things. That decision has to come out of a deep understanding of a particular problem. And so that deep understanding can only come out of, a lot of time investment. But critically, that investment can't just be in the problem. It also has to be understanding some of these technical details about how variables are measured, how covariances between this big vector of things and the measurement error work. So basically what we need is, I think, like, to your point, Carson, is more people who are bilingual, more people who understand both the depth of the problem, the data generating process, how biases get into the data, but also who understand how to build algorithms that work and to avoid some of these methodological pitfalls. And so I think that, and right now, we have, I think, emerging some pipelines for producing such people, but I don't see a kind of like widespread, we do have a pipeline problem because disciplines are disciplines and PhDs are PhDs, and there's no kind of like clear place that is producing such people. And so I think that people in the development community really need to invest in learning the methods, and people who come from the methods side really need to invest in spending time in one problem, not like writing like 10 different papers on 10 different fields, but like really investing time in one area and learning it well. Doesn't mean you have to be a doctor to work on health, but you do have to spend some time understanding health data.
Yeah. There was another question that just came in, so I'm trying to read it quickly. Let's see. What if we make AI algorithms curious, make them question the data sets and label choices they're getting trained on? For example, why Black patients are generating lesser health costs compared to white patients. This is from Artas Nath, and we have just 30 seconds to address that one.
So I would say this is another great example of why, of how hard it is to translate an abstract concept like curious into an objective function for an algorithm. There is no way to do that, and I think that that's the the miracle of human intelligence, the miracle of how we learn and how we process data is that we can do these things and algorithms cannot. So I would actually resist any effort to try to come up with automated fixes to these problems. I don't think those are going to be productive, and I think they'll give us a false sense of security.
Awesome. Well, we're at time. Thank you for this talk. Thanks for the questions that came in. I hope that this serves as a call to action and you know, I hope that this gives people optimism as you have about, our ability to sort of change the norms in terms of algorithmic development and also inspire some new partnerships that can help us be more equitable in the future. So thanks a lot, Ziad.
Thank you so much.